Does it say on your end that it's recording right now?
Yeah.
Okay. All right. Cool. So for today, is there any topic you want to talk about? Any questions? Um, Anything you saw like recently in school or on the
Uh,
internet that you want to talk about?
you're putting me on the spot.
No,
I
no
don't
worries.
off the top of
No
my
pressure.
mind.
Yeah,
Yeah.
yeah. Uh, do you listen to like Andrew Huberman's podcast at all?
No. Yeah. I
Mhm.
listen to Adam Meekin sometime, but that's
Yeah.
it.
Yeah. Okay. Cool. Adam Meekin's stuff is good. Yeah. So maybe let's talk a little bit about not so much about Huberman because I don't know. Here's my bias. I'm not a big fan of him, but Stuart McGill. Are you familiar with him? The
He
biomechanist from Waterloo.
he came out with the McGill method, right?
Yeah, the McGill Big Three. Yeah, which, for those people who don't know, is the curl up, the modified curl up, the bird dog, and then the side plank. Yeah, so they're supposedly known for spinal stabilization exercises. Did you
I've
guys
heard
learn?
of him, but I don't know much about him in detail or his method or anything like that.
Yeah, okay, cool. So maybe let's talk a little bit about that today. So, like you're familiar with the three exercises, right? The modified curl up, bird dog, and the side plank.
Yeah.
Yeah, yeah. So I guess from what I've learned, so he is essentially a PhD biomechanist at University of Waterloo. When I was in Cairo school, two of my profs that taught biomechanics were his like students. One of them had a master, the other one had maybe also a master or a PhD. So like a lot of the McGill stuff is taught, a lot of his research is taught in chiropractic curriculum, and I think probably a lot of physio school also been exposed to that. Mm. But yeah, so McGill essentially went on Andrew Huberman's podcast about a week ago, and then they talked about addressing back pain and things like that. So it was kind of interesting to say the least. I didn't watch the whole thing. I just watched bits and pieces, and I saw some other people like Adam Meekin, who was super critical of both of them, I guess. Yeah, because they said some things that were not necessarily within their scope, but also um, just was wrong, I guess. So I guess for my question for you is for somebody who came in with, let's say, acute low back pain. Let's say, just say I came in, I have no other medical history. I was playing tennis, and I somehow did a serve, my back started hurting, and I came to see you. How would you manage uh, this acute, non-specific, or mechanical low back pain?
Well, um, I do I do some tests to see like what could possibly be the issue causing it, like on the underlying issue. I'd look at the SINS model, what's the severity or debility, and how, based on those, how I can provide the best treatment for the patient. But there's no one specific thing that like one thing fits all. It just depends on like what's the underlying cause, what are the symptoms, what's the patient capable of.
Right, exactly. So you're saying that you need to have a really individualized and tailored like assessment so that you can find out what their issues are um, within a ballpark, and then you can sort of decide what to do.
Yeah.
Let's say, I came in to see you. Again, no major medical history, no major previous history of back pain, and no red flags, no neurological symptoms, no yellow flags. And then my back pain, let's say it's on my left side low back extension aggravated. I'm able to function, at least do most of the things, but tennis is not comfortable. I can still try to play, but it's just quite painful. And I'm
Mhm.
concerned about it potentially getting worse. Like if I came to your clinic, what knowing all that information and knowing that you've been pretty thorough with your exam, what would you do next, I guess?
I guess maybe I would start with some pain management, pain control,
Mm-hmm.
with some strengthening
Mm-hmm.
exercises,
Okay.
and just take it from there.
Yeah, and what would be like pain control, like things that you would do? Are you talking about like modalities? Are you talking about like manual therapy or
Both, a combination of both. I would provide a little bit of cryo, a little bit of maybe TENS,
or
and
some cryotherapy, like ice?
yeah, a little bit. And then I would possibly do some sort of manual therapy depending on their severity.
Mm-hmm.
Yeah,
Okay. And then after you say you're gonna do some like strengthening exercises, yeah.
strengthening. Yeah.
What would be like some typical exercises that you would give, or given my presentation, extension limited, flexion I'm okay, or vice versa, or if flexion is intolerant but extension I'm okay. Like how would you like what kind of exercise would you give me?
I haven't had theraps yet, so I'm not super familiar with exercises yet. But
Yeah.
I guess I'd start with something like maybe a sloppy push-up or something like that. Or I'm not really too sure yet.
Okay. Would you give like, something like a deadlift?
No,
No.
not right off the bat. No, I would maybe work towards that, but
Yeah.
I'm
What
not.
if a deadlift is a like a body weight deadlift or like a 5 pound deadlift?
It all depends. It depends whether the patient is like like is the patient capable of doing them? Is the patient comfortable with it? Is the
Mhm.
patient has have they done it before?
Mm,
Like it all depends on the patient. You know what I mean?
yeah, that's just me. I've done deadlifts before. I'm pretty comfortable with it. It's painful when I go into that position. Like, would you get me to do it?
Yeah. If the pain is not too severe and we're doing a low weight that there's not possibly of like aggravating your injury, yeah, why not? You know?
Yeah, yeah. I guess I'm I'm asking you these questions to kind of lead you to sort of what I'm thinking, right? Because yeah, like generally, I say again, of course, we need to consider the patient's presentation, their expectations, their experience with it. But a lot of times, I think as therapists, we are like almost too cautious with exercise prescription, and that's part of the criticisms with McGill Big Three is that they're like really low load exercise. They're essentially just all body weight exercises. So you're not really, at the beginning when your body's in a lot of acute pain, yeah, those are good options to start with, just get the body moving. However, there's no like way to you could progress them, but then like the ceiling is like here, right? You cannot really progress too far for the patient. So they're going to plateau very quickly versus with some conventional like weight training exercises. Um, you could increase the weights, you could modify the exercise a little bit, increase the depth of how far you go into a deadlift and things like that, so that you can really progressively progress the patient. Yeah, that's sort of my what I'm trying to get you to think about, I guess.
Yeah, no, I totally understand. Yeah.
Yeah, because in school, like we don't talk too much about exercise nutrition. At least, like when I was in school, what happens in our rehab course is essentially like, oh, these are the exercises. You have your McGill Book Three, and then there's some other named exercise or some protocol, but then they didn't really tell us why. They just said, oh, these are good for this condition. This is good for this condition. It's almost like a cookie cutter approach, right? It's like, how do we know all those people who have that condition are all going to respond to this exercise? How do we know like those people won't get aggravated or get harmed or get hurt by this exercise? And at what load or what frequency, what duration? Um, and so those are the things that are things that I think as physio and chiros we should think about more. Yeah. Any questions so far?
No.
Yeah. Okay. So let's say you picked a couple of rehab exercises, uh, or yeah, or how do you determine how many exercises to give the patient? Let's say my first time seeing you, you wanted to give me some exercises. Like, how many would you give me, realistically speaking? or would you like show it to me? Also, sorry, this is two-part question, I guess, or three-part. So would you show it to me, or would you just show me a video? Would you go through it with me, or would you just give me a handout? Like, what exercise, how many, and what would you
Well,
do?
throughout my clinical rotation, I would always show the patient how to do the exercise, and I would always be with them and cue them if they needed something or if
Hmm.
they were doing something wrong and I wanted to fix. But how many exercises? Again, it all depends.
Yeah, would you say you give one, or would you give like 10 or five? Like, how would you?
I'd say five is a reasonable,
Yeah,
on average.
yeah, okay,
Yeah.
yeah, yeah.
Maybe more, maybe less, depending on the patient's capability or their goals, or just it all depends. But just five,
Mhm.
I would say, is a good average number.
Yeah, yeah, yeah. Any thoughts on how many I would give?
How many? 10?
No, especially on the first visit. Like, depending on how much we get through, a lot of time, first visit, I might not even get to giving them exercise. But usually, if I were to give, I give no more than three. Um, Oftentimes, I actually on the first visit ask patient, "How many exercise do you want me to give you today?" Um, I say one or two or three. Ask them to pick, but I try to limit at three because once you give more than like three, first of all, patients they might not remember any one of them, remember them well, and especially if you want them to do each one of those exercises well, the chance of you succeeding is slim to none. So if you give them one, two, or three, at least they don't have too many choices. That at least can get one or two done properly, if you will.
No, I totally get that
Yeah,
because if you overwhelm them, they might just be like, "Oh, this is too much. I might not even do it." But if you give
exactly.
them like one or two or three exercises to begin with, um, chances are they're more likely to gonna stick to it. And during the initial eval, you're probably gonna be so busy just trying to do the evaluation that you're probably not gonna have time to go through exercises and give them proper exercises anyway. So
Yeah,
yeah.
exactly. And then there's that famous line that we all often say: the best exercise is the one that patient is doing. The worst exercise is the one that they're not doing. Right. So you could give them 10, 5, or whatever number great exercise, best exercises, even though they don't exist. But then if they can't do it, or forget to do them, then it doesn't do them any good. Versus if you give them one exercise they can remember, they've done it before, it makes sense to them, or three or whatever that limited number is, then at least there's a higher chance for them to stick to it. Yeah, cool. Um, Exercise prescription wise, let me think. What else do I want to talk about? Um, like what have you guys learned so far in school? Like open chain exercise, closed kinetic chain, and like do you guys talk about like principles of like strength and conditioning?
Um, yeah, we've learned a lot of that. I guess the curriculums are a little bit different, so um, the courses are a little bit different. But we've learned a lot of neuro so far. Um, a lot of just MSK stuff.
Mm-hmm.
Um, yeah,
And neurological conditions that like I guess at least the ones that we could treat like peripheral neuropathy, radiculopathy. Like, did you guys learn things like nerve flossing? Like,
yeah, we have.
yeah,
So far we've mostly like our main focus has been like things like stroke and um like Parkinson's disease, MS, things like that.
yeah.
Yeah, we have a pro bono clinic that we have to volunteer at as a part of our curriculum, and we have a lot of uh, um, CVA patients there. We have a lot of TBI, a lot of Parkinson's, MS, things like that. So we get to work with a lot of these patients firsthand, which is
Mhm.
nice experience.
Yeah, I see. So those are some of the conditions, I guess, I wouldn't see that frequently as a chiropractor because those are like, like life or death, right? It's like CVAs and like, yeah, and then even like Parkinson's and MS, those are like mostly like upper motor neuron lesions and conditions where, yeah, it's not what we see commonly. So what do you guys do normally for those cases?
So we have a program called Heart,
Hmm.
where we provide like actual physical therapy services to these patients, and like you would in an outpatient clinic. Um, in We also have a program called Move More,
Mm.
um, which we take a lot of CVA patients for walks and stairs and things like that, and just get them moving a lot, you know.
Yeah.
And we also have a program called Power, which is Move More but for Parkinson's,
Hmm.
and we have where Parkinson's patients come in, and we pretty much take them through. We try to make it a lot of like fun as much as we can, but as well like have them move and exercise a little bit. Sometimes that may include like having them dance or
Mm.
but we try our best to get them moving and just exercising a little bit as much as we can.
Yeah, no, that sounds great. Yeah, this is where like the specificity of the exercise prescription does not matter that much, right? It's like you just get them moving, get them active, get their heart rate up, get their blood flowing. That's
Yeah,
actually more enough or more than enough to at least progress them to the next stage, right? Versus,
yeah,
like I guess if you and I were at a private clinic, then our prescription of exercise may need to be a little bit more specific to the patient needs, especially let's say they're an athlete trying to get back to a sport, they need
yeah,
to really strengthen one specific skill or area of their body, or if they have like my low back pain, like we need to be a little bit more specific. Can't just give me like shoulder shrugs for a back pain case.
yeah. I also feel like in an outpatient setting or in like a acute care setting, they don't have the manpower to like spend so much time and like be with these patients all the time.
Right.
Over there, we have students that are dedicated to just they have patience for like that shift, and they're like all their attention is on that patient, getting them through what they need to, spending that amount of time with them, and they always like hundreds and hundreds of students just to take care of those patients, you know.
Right.
So it's like they get a lot of like attention and care, and just it's nice. A lot of these patients, when they come to those programs, they stay and they're like, I feel really good when I come here because I get encouraged by you guys, and
Hmm.
like it's the psychological aspect too, and not just the physical aspect. So
Yeah.
yeah, it's patients love it over there. It's
Yeah. Yeah. Especially like I'm assuming some of these patients are probably like middle age or older where they have it's right. These are not necessarily conditions that are experienced by like young patients. So when they interact with like students who are young like yourself, then I guess for sure it brings a little bit more sense of energy and some dosage of youth, I guess.
Yeah, most of them I would say are on the older side. We do have some young patients there,
Yeah.
but most of them I would say are on the older side. But um, you would not be able to tell that from their spirit. They've got like a lot of them got a lot of spirit, and
Yeah.
yeah. I worked with a couple semesters ago. I worked with a CP patient at heart,
Hmm.
and he was quite young, and it was just he's been coming to the park for years, and
CP means cerebral palsy.
yeah. And it was really rewarding working with him. You know, it was just you learn a lot, and it's
Mm.
just for us it's really good experience, and for them it's really good care. So it's like shooting two birds with one stone. You know.
Yeah, definitely. It's great that they're, well, it's not great that obviously they're suffering from these conditions, but it is a great, like, gift almost for students, right? To just absorb and see things firsthand, because we can learn these things in textbooks and, through reading articles, but unless we have that like firsthand experience, then we really don't know what we're dealing with.
Yeah. My biggest experience with that, I can tell you off the top of my head, was, for example, like spasticity. You read about it in books, you study it, and you know the details, but when you go in the clinic and you actually see what spasticity looks like, what it feels like,
Yeah,
it's just completely different. You know what I mean?
yeah, yeah.
You don't fully understand it until you feel it and you see it.
Yeah, yeah, yeah. And then you're the first time you see her, like you're like, holy cow, this really happens.
Yeah.
Yeah. Yeah, I have a similar story, I guess. I've been treating this gentleman. He got into a motor vehicle. It was on a like a motorcycle and fell and fractured his spine. And yeah, like they said he wouldn't be able to walk, and now he's like walking, trying to run, of course, with some impairments. But yeah, it's like when I work on his upper limbs, sometimes like I'm stretching him, doing some movement, all of a sudden his arm just like seizes up, and, like can't budge. And like the first time I saw them, I got scared. He's like, "Don't worry, that's just my normal. It happens pretty frequently." So you're just like, "Whoa, your body does some interesting things." But yeah. Um, what was I gonna ask you? Um, shoot. I guess I've been asking you a lot of questions. Do you have any question for me?
No, I'm just having a good time chatting with you
Yeah,
and learning.
that's good. Yeah. Alrighty. Well, let me come up with some more questions, because I feel like, also me, through me asking you some questions, I get to learn a little bit from, your perspective, your educational program. So I'm getting a free physio degree at the end of this, which is good. Um, what are some of the challenges you see um, with working with the patients that you have worked with,
um,
or the cerebral palsy patient?
um, Sometimes it's just um I had a patient who, sometimes these patients come to the clinic and they're there all day. They start with like OT, and
Mm.
then they move to like move more, and then they have part after, which they like go to see like PT. And by the time they get to PT, they're kind of out of it and they don't want to do anything, and it's just they're tired, and it's like they're not motivated to do anything, and it's just really hard to get them within
Yeah,
that session that we have to really accomplish anything.
yeah,
So at that point you have to kind of reassess and see, what can I get out of this patient during this 1 hour that I have with them.
yeah,
So that's one of the bigger challenges that I've ran into. um, Another thing is, like in the clinic, sometimes you're working with like neuro patients, and they have a stat here where like 80% of PTs go on like disability within like the first year or two of practice or something like that.
they're burned out.
Yeah, and it's just, I worked with like a neuro patient in my last clinical rotation. He was like 6'5", like 300 pounds, and it was
Yeah,
just to get him like transfers and like bed mobility and things like that. It was just a lot of physical strain on us. And it's just another challenge is things like that. I'm not super experienced yet, so I I haven't ran into many challenges yet, but those
yeah,
are some things that I can think of off the top of my head.
yeah, yeah. I mean, these are very interesting, like, challenges, and very challenging to say the least. Yeah, like the first one you said, patient already, like, by the time they get to you, they're already burnt, they're already exhausted, they're drained from their previous visit. So like you're already like set up in a way that's you're not gonna be able to get much out of this encounter, right? And the patient probably won't get much out of this encounter. So like, how would you like? What would you say would be a good way to solve this issue, not just from your end, but like in the global aspect of this patient's care? Like, how do you think this could be addressed better to be? Uh,
Maybe scheduling therapy a little bit better so that the patient is not in therapy for such long hours every day.
yeah.
Maybe there's a break, or maybe that different, like maybe OT and PT are not scheduled for the same day. There's OT on one day with a little bit of move more, and then there's move more and PT the next day. Or just if we have no choice and it has to be that way, again, just talk to the patient, see where they're at, see what you can get out of them, and just try to get maximize, even if it's a little bit, like
Mhm.
something is better than nothing. You know what I mean?
Yeah, yeah. So you mentioned some efficiency in booking them in terms of scheduling. So that's definitely great. That would definitely help. What do you think of like, if the PT and the OT somehow has some sort of like rounds, they discuss what they would do each individually, and then they come up with a more of an interdisciplinary plan together, so that the patient can still see both of them at the same time. Like they come up with a plan that's together, so like they're not doing overlapping things, and then the efficiency of each of their therapy hopefully will be more higher. What do you think of that? Would that be?
That would be like the perfect best case scenario that could be.
Yeah.
Um, and I could see how that like would be most beneficial to the patient as well as the therapist. But as personally, like in the setting that I work at in that proponent clinic, we're all students and
Yeah.
we all have like our specific shifts. So it's like really hard to, especially
Mhm.
since we don't know each other. The occupational therapy students don't know the PT students, and the nursing students don't know any of the other students. It's really hard to like coordinate and and just get everything like coordinated with each other. But I could see that happening in like outpatient care or like acute care.
Yeah. Do you guys have like clinical rounds between like different disciplines, like once a month or whatever it is?
No, the closest thing we had was we had like a field trip where we went to a PTA program,
Mm.
and we kind of got to get to know the PTAs and just work with them a little bit and see how things go. But no, we don't have. The only place we see other professions really is in our pro bono clinic where we work with nurses and OTs usually.
Yeah, yeah. I guess that's probably why I wanted to set up something like this, is that like, we all are great at what we do each individually. Obviously because we go through a lot of school, but then a lot of times just like we have a lot of things that we don't know what, like let's say I wouldn't know what you would do as a physio, and you wouldn't know what I would do as a chiro versus an OT. So when we have these like regular or somewhat regular like discussions in a group setting, that will be a lot easier to at least coordinate things and comprehend one another and learn from one another. And I think now a lot of these like clinics, they're not just multidisciplinary, they're interdisciplinary, which means that multidisciplinary just means that they're each one of these clinicians, but then they all work sort of separately. But interdisciplinary is like where they meet regularly as a team, and then they try to solve a case or sort of help a patient. So that way, I think it would be best, like you said, for a patient. But that would be very time consuming and hard to coordinate.
That's the type of practice I would want to have in the future.
Yeah,
Not only with like OT, PT, whatever, also with like psychotherapists,
right.
social work,
Yeah,
um,
physicians and yeah,
yeah. So it's like attack like the problem from multiple different angles rather than just everybody working on
yeah,
their own.
yeah, yeah. which that would be, I think, fundamentally would be ideal. And yeah, I know a lot of hospitals they do that. They just say, yeah, that would be best case scenario. I would love to work at a organization like that at some point, right? So that like also the burden wouldn't just fall on each individual clinicians, right? Because it's a shared workload, shared decision making, and obviously some people take lead for certain things that they're expert in. Yeah, so
And in my like limited experience working with different professions, I really appreciate like the different perspectives that the different professions bring to the table
yeah,
in taking care. And I feel like having those different perspectives will kind of lead to the like the best like the optimal type of way to like treat a patient and care for a patient, you know. So yeah.
yeah, definitely, yeah. And healthcare is so like broad, right? Like there's the physical, there's the psychological, emotional, and then spiritual, if you believe that, and there's so many different aspects, and we're all good at our own thing, but then we're all looking at it from different angle. Like we're almost like different slices of pizza, but then there are more than one of there's a few of us together, then we form the whole pie. I guess that's a horrible analogy. You know what I mean.
No, I definitely know what you mean. Yeah.
And the second thing you said that was challenging, burnt out of the PTs or the PT students. So it sounds like it's more of a like a physical type of disability that they're experiencing, not so much like psychological.
Yeah, it's just some aspects of our work are physically challenging, and
Yeah,
it puts a lot of strain on our own bodies. So it's like we're trying to provide care for patients, but at the same time we're kind of breaking down
and
our, you know,
yeah,
in that process. And it's just yeah.
yeah. How I guess how would you solve this problem? I mean, ideally, or in your perspective.
I mean, there's really nothing you can do other than just be aware of your body mechanics, I guess, as much as you can. Try to just do everything with best body mechanics you can, but it's like we're not like perfect beings, and we can't like
Yeah,
always be cognizant of
we're
our
not
body
machines.
mechanics. So
Yeah.
it's like I don't see what we can do other than that, but it's just yeah.
Do you want my perspective on this?
Sure, absolutely.
I mean, if we stay healthy as much as we can, right? Eating well, sleeping well, work out, lift weights, run, whatever it is, that's the best thing we could do to improve our health. And I think the chance of these physical injuries would hopefully decrease.
Yeah,
Right? So that's one part. But the other part is also like, yeah, like we cannot control how physically demanding the job is. So take vacation when needed, right? Like talk to your superior. It's too much, right? Because again, part of it is like we don't want to be like taking advantage too, right? As workers, as whether you're self-employed or you're like employed or whether you're a student, if these things consistently fall on you to nobody's going to care about you other than yourself, right? So you have to advocate for yourself, your own health. um, yeah, and then the other thing is that hopefully, in the future, as like right now you're not independent practitioner or clinician, but hopefully in the future, when you work with patient as an independent clinician, you could provide education to patient on the importance of managing weights um, and promoting self-efficacy, getting more active, so that hopefully less of patients that are more overweight or obese. Again, this is not to shame anybody. Of course, these things are very complex, but hopefully people, the general population gets more healthy. So
yeah,
it becomes less burden on us and overall on the healthcare system. But that's going to be, that wouldn't happen just over a night or a year or 10 years, right? That might happen over a long time or might not, right? Sorry.
Sorry, Dr. Jason. I'm getting a knock on my door. Just give
Oh,
me
no worries. No. If you gotta answer.
Sorry about that.
No worries. Everything okay? Sorry?
Yeah, no, that was just my brother.
Oh, okay. Maybe he wants to join the fun. Yeah. Yeah. So essentially, yeah, it's like there's things that we could do to improve ourselves, but then there are also things that we can hopefully educate our patients on, so that the overall population gets less tough on us, I guess.
Yeah.
Yeah.
These are complex issues and they require complex handling of the matter. So
Yeah. It's everything is so like multifactorial, so like complex, right? If only there was one simple solution, and these solutions that I'm offering or my perspectives are still like very simple, simplistic, and there's a lot more, I guess, nuance behind all of that as well. But yeah. Anyhow, yeah, it's interesting how initially I wanted to talk about the McGill victory, and now we kind of shifted our gear toward this current topic. Yeah, anything you wanted to talk about?
not specifically. I've enjoyed our conversation so far.
It's good. Good. What was I say? So what's happening, I guess, now moving forward? For now you've done your summer semester, now you're just waiting for your fall semester now?
Yeah, so I have a month off. I finished on July 24th, and I have until August 25th off. We start our new semester on August 26th, so just a little bit of time for us to cool down from a tough year and for us to unwind and just get back to things refreshed. And yeah.
Yeah. Okay, so you're now back in Toronto?
Yeah, I am. I'm home right now. Yeah.
Okay, right. Your brother's here.
Yeah.
Yeah, that's good. And then once I guess this fall semester starts, what I guess courses are you taking? Or
Let me actually look at my schedule. I have cardiovascular conditions examination and management. I have neuromuscular examination and practice 1. I have Therex, which is coming up.
so
Pardon me?
what was that?
I have Therex, which is coming up, therapeutic exercise.
Okay.
And I have I have a clinical rotation, and I have the pediatric conditions.
Mm.
Yeah.
Yeah. Yeah. That's yeah, I think it sounds like this upcoming semester is gonna be a lot more like applicable to what you're actually going to be doing, right? A lot of like assessment, learning about different conditions, and then giving like exercise therapy, and then pediatric conditions. So you'll be able to assess for those things. So
Yeah, I'm really excited about the pediatrics course. We haven't learned much about pediatrics so far in first year. So I'm excited to learn that. And Therex it's definitely needed, you know. So yeah.
Yeah, and hopefully, I mean, I think now the education system, curriculums are probably better than, let's say, when I was in school. So hopefully, yeah, you'll get lots from it. And yeah, have you thought about like courses that you want to take in the future, like after school is done?
Yeah, I'm kind of
Or anything that like your classmates talked about, like that they wanted to take? And
I'm personally trying to take course after I graduate. I'm trying to take courses on muscle energy and things like that, as well as like water therapy, you know. I'm trying to incorporate like things like that into my practice. So yeah, that's certainly something I want to start with, and I want to teach eventually. So I want to get specialized in something within the PT field so that I can teach that way.
right, yeah. So
And right now, my biggest interest is neuro. But I don't know if that's going to continue to be the case, but yeah.
yeah, yeah. I mean, obviously, things might change or might not change, but the most important thing is that like you want to teach, you want to learn. So as you progress with your career as a student, as a PT in the future, like you're gonna just having that open mindedness to learn. I think that will serve you very well, and it's gonna take you far. So I hope one day I get to take one of your courses in the future. So.
Oh, thank you. I appreciate that.
Yeah, so, keep learning, keep honing your skill. Um, yeah. Um, have you ever thought about like, I don't know, taking things like acupuncture or on like some sort of like manual therapy, Graston, or like,
Yeah, I have. I do want to learn acupuncture. And I do want to. I'm very passionate about manual therapy. I know that it may not be the best thing, but it's personally it makes me feel good, and
Mhm.
I know it makes people that I work with feel good. So I would like to improve my manual therapy skills as much as I can. So I'm definitely gonna go in that route as well. Yeah.
Yeah, yeah. And also like there are like different schools of thoughts for manual therapy, right? But if you think about it, like, there are physios and chiros that like almost like bash manual therapy. But then if you think about it, how many physiotherapy PTs and chiros don't do manual therapy? Like very little, right? We'll
Hmm.
all do some extent. So it's just that how we do it and how we like explain those things to patients, I think that matters more, right? Like we got to do some manual therapy. If a patient come in, you're just like do exercise, do exercise. We might not get too far, and exercise is just one way to get people better, right? So yeah, definitely having more tools under your tool belt is important. Yeah, and at the same
Yeah.
time, yeah, like if you like having enough tool belts, but tools underneath the tool belt, but also like be expert in like a few of those that really you enjoy or have good evidence. Yeah.
Yeah. One analogy that one of my professors made was that, like, what's Batman's belt called? He's like, he's like all my tools are like in my belt, and I like it doesn't matter what kind of patient comes in. I have all these tools that I can pull out and just whatever I need. And the more tools you have in your belt, the more applications you have to like different patients, different conditions. So it's yeah, but I forgot it was like Batman's belt, something like that. It's
Yeah. Yeah.
not important, but yeah.
Yeah, definitely. Just having more knowledge, more broad knowledge of everything can help, right? So and then, yeah. Though I want to play the devil's advocate, right? It's kind of like that exercise. If the patient comes in, I gave them 10 exercise, they could have done 10 exercise really poorly, all of them, right? Or so also like when we have enough, at some point we need to recognize like this is enough that we need to get really good at these each one of them, or at least pick three of these tools that we get really good at, but we still need to know the other stuff. So it's like we need broad like knowledge, but also need depth of our knowledge as well. So that's both are important.
Yeah, definitely.
Yeah, yeah. So yeah, I think like just from my personal experience, like I've taken like an instrument assisted course, kind of like Graston. I've taken acupuncture. I've taken like some taping stuff. And a whole like some like TMJ management, TMD management, pregnancy course, and then the FRC, FRA, FRISM, all that stuff. So my perspective is that what acupuncture is like right now I rarely use it. When I just took the course, I use it more.
Hmm.
But then now, like based on the things that I see, also based on the things I read and research, it's like acupuncture is just pain control modality. I don't hype it up, right? Also, the instrument assisted soft tissue mobilization stuff. Again, it's just one of the things I use to manage pain. I used to use almost every patient right after I took the course back in 2018. But now, like if I think back in the last 6 months, I might have used it 3 times.
Yeah.
So this is where I'm trying to like, I have enough things. I'm just trying to figure out, okay, these things I actually don't really need, and these are things I actually really need to get better at. So now it's just things like strength and conditioning. I'm trying to read up on those things. Obviously, patient education. Those are things that we don't stress enough. I think it's like once you provide good education to your patient, provide good reassurance, and not trying to scare them, this actually solves like, I don't want to give you a percentage, but a big portion of the problem. Even though we haven't even touched the patient, haven't done any manual therapy or given them exercise. I think that's one thing that, like, at least I've been trying to hone my skill in, and that's something that I want. Also, like as part of this group, I want people to recognize that's actually almost more important than the physical things we do for patients, even though those are still important.
Yeah, definitely.
Yeah. Yeah. Because like lately I've been just looking at different clinical guidelines. It's always like, the things that work really well is always education, reassurance, and providing some like tips. And then the manual therapy, spinal manipulation, uh, modality, they're all like lower down, like NSAIDs and medication, they're all lower down. So it's like, oh, if those are the things that have been proven to work really well based on a lot of research, a lot of clinical guidelines, a lot of meta-analyses, why aren't we trying to get good at those things?
Yeah, definitely. Oh, that makes a lot of sense.
Yeah, yeah. But these things didn't come to me like in the first like 3, 4, 5 years of my practice, right? Because that's why I'd taken all those courses. I'm trying to figure out, oh, which are the tools that I need the most, and then later on, I'm just like, oh, okay, let's rethink a little bit.
Yeah.
Yeah, yeah. So for sure, I think you will encounter like plenty of challenges as you start to practice, especially when you practice independently. And then you're gonna have so many questions, and you're gonna have days where you're just like, I don't know what I'm talking about. I don't know anything. Right? So, like, I'm holding my patients back. It's my fault the patient not getting better. Yeah,
No,
those
I
days.
can see that. I
Yeah,
already feel that way. And
yeah,
I'm not even practicing independently yet, but yeah.
yeah. So be prepared for those days. But hopefully you remember these words right now that this conversation, that it's not your fault. It's not because you don't know any better. It's not because you don't know anything. It's because a lot of things are not necessarily within our control, right? Um, you've learned, you've heard of social determinants of health.
Yeah.
Did you guys talk about? Yeah, probably in public health or something, right? So those are just different factors outside of our biology, outside of genetics, outside of our biomechanics that influence our health and our well-being. So and those things are like not great in a poor state or condition. No matter what we do, no matter what we try to massage them and then crack them, it's not gonna get them better that much, anyways. Alrighty, okay. Um, I guess it's been almost an hour. Gee. Anything else you want to talk about today before we wrap it up?
No, it's been great, and it's been very nice chatting with you, and I've enjoyed it. I've learned a lot, so thank you.
Yeah, no, thank you for your insight and your perspective as well. I think sorry, I probably talked way more than you did.
No, you're good.
Yeah, but I try to ask you some questions, and I'll try to come up with better questions next time. For next month, I'm inviting somebody to talk to us. You may have seen him on social media. His name is Dr. David Newton. He's a chiropractor. He has a page called Clinical Concept, I think. Clinical Concept. Let me look it up. Uh, oh, sorry, I can't type. Yeah, clinical concept. I guess his description is we help students and chiropractors gain confidence in evidence-based patient care through our mentorship and community. So he essentially recently started this podcast too with a couple of really famous people. So
Okay.
I think he will have some time to talk to us on our next session, which I think I proposed for August 25th, I think. Are you available that day?
Um, yes, I'm probably available. That's my move-in date for
Mm,
moving into my apartment, so I
I
might
see.
just be busy moving, but I would probably be able to attend the
Mhm.
online session for a little bit. It wouldn't be a problem, yeah.
Yeah, and don't worry if you're absolutely busy. So for this, I'll record it anyways, and I'll try to make it available later. But I think the session will go more so like we just come up with a list of questions, and then we'll just ask the question to him. He'll just more do a Q&A kind of thing.
Okay.
Um, so that would be good. So I'll come up with a couple questions. In the meantime, hopefully you can come up with a few questions for him, anything clinical related, maybe even business related if you want. And then I'll ask the others in our group, hopefully come up with some questions, and then we'll have a discussion then. Hopefully we'll have a pretty good turnout.
Okay. That sounds good. I'm looking forward to it.
Yeah, I think it would be a great learning opportunity for all of us. Yeah, so cool. So that would be August 5th. I'll send the link later once I get a little more detail as well. Okay.
Okay. Thank you so much.
All right. Thank you for your time as always. And we'll chat soon.
Chat soon. Have a great night.
Yeah. Peace.
Bye.